Just to set the stage, I'm going to discuss about many new drugs, new regimens we have, and which could change the way we envision the treatment of our patients. I think we all accept and agree that we have very good and many regimens in terms of efficacy, which can achieve success in most patients with susceptible strains. But we have still problems with regards to tolerability of some of the regimen, CNS issues, GI, hyperbilirubinemia, hypersensitivity, and more patients are asking for convenient regimen, which they can cope with their daily life, not only dosing frequency, but also food constraints and taking into account co-medications and drug-drug interactions. Long-term toxicity, we are still using a lot of the protease inhibitors, although we know they are associated with metabolic, sometimes lipodystrophy and excess cardiovascular risk. And we still have some issues and concern with regards to clinical impact of some regimens on the bone, on the kidney. So we have to be very cautious on these aspects, because this tolerability, convenience, and toxicity should not compromise the high efficacy we have obtained with the new regimens. So today, if we look at the different third agents we have namely three classes: the NNRTI, the PI, and the integrase, which are coming up front. We have not a perfect drug yet, as we have tolerability issues with some of the NNRTI, especially with Efavirenz, CNS adverse events, skin rash, hyperlipidemia. The boosted PI, as I said, is associated with metabolic disorders. We have also improved convenience for some regimen, but some regimen needs many pills. Raltegravir requires twice daily dosing. We have co-formulated fixed dose single pill tablet, but these are fixed, predefined, and we cannot play with that, and we have to take what is in the STR to propose to our patients. So we'll have more options soon, so we can choose between the different STR based on their different advantages. We have still also many regimens with either cobicistat or ritonavir, which are prone to drug-drug interaction through cytochrome P54-3A, and this is a problem with long-term therapy, with communication, with aging patients. So this is something we need to take really seriously into account. And with regards to drug resistance, we know that NNRTI are all associated with risk of resistance and rather low barrier, genetic barrier to resistance. The PI, boosted PI, when they are boosted, have a high genetic barrier to resistance. But for the integrase inhibitors, we were all quite confident that this class of drug, because of the high potency, will be also less associated with resistance. But we have had some data showing that when patients fail Raltegravir and Elvitegravir, they have possible resistance emergence. So now we have a third integrase inhibitor which is coming along, which has probably some benefit with regards to tolerability, convenience, drug interactions, and drug resistance, and this is Dolutegravir, and I will discuss some of these different aspects during my presentation. So when we look at the different guidelines, I didn't put the Canadian one, sorry for that, but I'm sure you have the same as in every country, that is selecting either Truvada or Calvexa plus a third agent, which is either an NNRTI, a boosted PI, mainly atazanavir, darunavir today, or more and more in the guidelines, one of the integrase coming as recommended first line. So I think based on the recent data, it is maybe time that we select even more the drug we select for first line based on the new need to have not only the best potent regimen, but also the best tolerable one. And for this reason, we just published an editorial, an opinion paper with Anton Pozniak and Mark Weinberg discussing whether it was time to abandon efavirenz for first-line therapy. And one of the reasons is for the recent publication, well, it's in press, it should be released soon, of the increased suicidality and suicide rate with efavirenz compared to efavirenz-free regimen. And this is based on a meta-analysis by ACTG, which looked at 4 randomized clinical studies. In total, over 2,000 patients were randomized in these 4 studies, 3 open-label, 1 double-blind, to efavirenz, and over 2,000 to non-efavirenz regimen. And the suicidality rate was 2 times higher and very significantly with efavirenz compared to non-efavirenz. And when they looked at the cause of death, death by suicide, accident, substance abuse, homicide, or unknown cause, was also the risk was 2 times higher, very significant with efavirenz compared with non-efavirenz, while for other cause of death it was not the case. So clearly there is a strong signal with regards to efavirenz, not only the classical CNS symptoms and psychiatric symptoms or insomnia or dreams within the patients, but patients also can have more severe psychiatric symptoms. And in the multivariate analysis, the risk associated with efavirenz was independent to all the other risks associated with increased risk of suicide. The second reason I think we should be a little cautious with the use of NNRTI first line is the fact that there is an incidence of a prevalence of 5 to 8% of resistance to NNRTI baseline in the patients we see. Of course, we can detect most of them by genotype sequencing, classical sequence, but we don't detect with a classical genotype minority variants. And we know that nowadays the minority variants are increasing, and that they can lead to increased rate of failure when you select NNRTI upfront. And probably in some patients in which we find a failure on the first line efavirenz, we say, oh, he was not adherent, he didn't take his drug. Probably it's not always the case. It could be just that he had a minority variant we did not detect because we did only classic genotype upfront. So if we want to stay with the NNRTI class, I think rilpivirine has some advantages over efavirenz with regards to toxicity, and especially in the patients with low baseline viral load, which represent the majority of the patients we see in less advanced stage. If we detect patients early, you see that most of the patients are below 100,000 copies. And in this setting, in first-line therapy, the STR of rilpivirine, tenofovir, FTC, Complera perform as well or even better than Atripla, with a difference which is highly significant, showing even superiority of Complera over Eviplera. So I think today, if we want to select an NNRTI first line, we should restrict it to patients with low baseline and select Complera instead of Atripla. And this is because the toxicity and the CNS and psychiatric effects are significantly less with Complera than with Atripla. And the patients who discontinue because of adverse events are much lower with rilpivirine than with efavirenz. And I don't think we can still accept a rate as high as 8 or 10% of discontinuation for a first-line regimen just due to adverse events now that we have much better tolerated regimens. When we look at rilpivirine, we can also, when we consider rilpivirine, we can also discuss it as a switch strategy in patients well suppressed. And this is a trial where patients on boosted PI suppressed for more than 6 months were either continued on the usual PI or switched to rilpivirine, FTC, tenofovir, Complera. And these patients had very restrictive exclusion criteria with regards to prior NNRTI use or any NNRTI resistance to be on the safe side. And when you select correctly the patient, then you can see that you have a high rate of maintenance of virologic success with Complera compared to the continuous boosted PI, 95% versus 89 to 92%. And what is interesting is that the success of the maintenance is the same whether the patients had historical high or low viral load before ART initiation. So I think this is maybe the way to position Complera. And of course, because the patients were switched off the PI, they improved their GI symptoms. They had less fatigue, less headache, less general symptoms, and they were more satisfied by the new regimen. But we must remember that rilpivirine has also many limitations. One of the limitations is that it has to be taken with meal. Many of the drugs we use, we recommend to take it with meal, but this is not a recommendation. This is a strict need to take meal with rilpivirine. Otherwise, we are rapidly, because of the rather short half-life of the drug, faced with suboptimal concentrations. And because the genetic barrier is low, you will have rapidly a breakout and a resistance and a failure. Drug interactions also important. PPI are strictly contraindicated. If you want to use drug for the stomach, you need to use H2 blocker or antacids and to take it really apart from rilpivirine. And even with that, you are not sure that you will be safe. So clearly for me, any antacids or PPI is a contraindication for rilpivirine. There are also many interactions like any NNRTI with cytochrome 3A4 inducers. So this is not a limitative list. So we need to be aware that rilpivirine has many limitations. The inhibitory quotient is less than efavirenz, so it's weakened than efavirenz with regard to that. But if it's taken in the right conditions, it's perfect. But you need to be sure that there is the right conditions for the patients. Also, there are some cases of hepatotoxicity and insomnia. I spoke about the low genetic barrier to resistance, and what is the major concern for us in our clinic when we prescribe rilpivirine is to be sure that there is no NNRTI mutations on board. And for that, we look at pre-therapy plasma. And we are lucky, as you know, because we keep in the lab all the plasma for the patients for more than 10 years. And so we can go back to the historical plasma and reanalyze the sequence with the new mutations to see whether there are any mutations impacting rilpivirine. And if the patient is suppressed on therapy and if we want to switch on a suppressed patient, we do genotype on the DNA, on the cells, to look if there are any NNRTI or NRTI mutations. And we do that. When we do that, we eliminate more than 1/3 of patients who are eligible to rilpivirine, but who are not more because of the existing backbone NNRTI or NRTI mutations. So let me now turn to the integrase inhibitors, for which we have 3 drugs, and all the 3 drugs have shown very interesting results. And I think we enter a new area where we will have to rethink our strategy and to position at the top front the integrase inhibitors. This is a new paradigm of therapy for us after the phase of NNRTI and PI. Now we have the integrase, which are going to change probably a lot of things. And we have very nice data showing that Raltegravir is superior to Efavirenz, Dolutegravir superior to Efavirenz, Dolutegravir superior to Darunavir. We heard at last CROI that Raltegravir is superior to Darunavir, Atazanavir. I have also presented results on the NEAT showing that Raltegravir, Darunavir is non-inferior to Truvada, Darunavir, but this is not a classical regimen, so I won't elaborate on that. For switch, we have a study showing that Elvitegravir, Kobe, Truvada is superior to Truvada PI, and I want to also discuss a little of some of the results of the SPAR study, which is a switch from PI to Raltegravir. I won't cover experienced patients for the sake of time today, but we know that the integrase are a very potent class and they can salvage many patients, and we have very nice data, especially from the saving study in which Dolutegravir was even superior to Raltegravir with a backbone of optimized regimen. So let's go back to the results in first-line therapy with the classical 2 nukes and third agent, where we have the START-MERC study showing after 4 and 5 years that Truvada Raltegravir is indeed virologically superior to Truvada Efavirenz, and this is despite the fact this was a double-blind study in which a patient had to take BID, placebo, or Raltegravir for 5 years, and despite that, Raltegravir still won over Efavirenz after 4 or 5 years, and there was also superiority with regards to immunologic recovery. One of the reasons was probably the fact that Efavirenz over the years was associated with a high rate of discontinuation, while for Raltegravir there was only minimal discontinuation, and this was very stable after the first year of the first 4 weeks of follow-up. With regards to Raltegravir, we have also very important new data showing in a large ACTG study which was presented at CROI 2 weeks ago that it is superior to Atazanavir and Darunavir in first-line therapy when combined with Truvada. This was an open-label study in 1,800 patients, open-label, and they had 2 endpoints. The first one was virologic efficacy, and there was equivalence for the 2 regimen, for the 3 regimen, the integrase and the 2 PI, while for the tolerability endpoint, Atazanavir performed less well than Darunavir or Raltegravir, and this performance of Atazanavir was linked to what they call cosmetic hyperbilirubinemia, but it's not only cosmetic, it's also clinical and stigma, and also the GI problems were more prevalent with Atazanavir. When they did the combined tolerability and virologic efficacy analysis, there was clear superiority of Raltegravir over both PIs and of Darunavir over Atazanavir. The only point where Raltegravir was inferior to the 2 PI was with regards to resistance, because there was a higher rate of resistance in patients failing Raltegravir. Although the failure rate was globally low, patients failing Raltegravir developed resistance to both integrase and NNRTI, which was not the case in the PI group as expected. So if we look at the composite endpoint of virologic and tolerability failure, you see that there is a large difference between Raltegravir and Atazanavir, 15% more failure with Atazanavir globally over 2 years than with Raltegravir. So clear superiority of Raltegravir, the same between Raltegravir and Darunavir, and between Darunavir and Atazanavir. So this is a real-life situation where we don't look only at virologic endpoint, but also at tolerability of a regimen over time. And this is reflected in the snapshot analysis where patients stopping their randomized regimen on the right are counted as failure. You have 80% of success overall with Raltegravir at 2 years, with 73% with Darunavir and 63% with Atazanavir. So a large difference between the arms. When we have a more classical ITT as randomized study, which is you look at the patient based on what they were randomized on, whatever happened to them, whatever regimen they were switched to, you have less difference, but still you have 94% of patients started on Raltegravir who perform very nicely as compared to 88 and 89% with the protease. So still some advantage to start with Raltegravir in this study. The second integrase I want to touch on is Dolutegravir, which is co-formulated as a single tablet regimen with cobicistat and Truvada. And there are two major phase 3 studies with now 144 years of follow-up with very similar results at 1, 2, and 3 years of follow-up, showing that Stribild is non-inferior to Atripla. So we have seen that with Raltegravir we had a difference. Here we don't see a difference between Stribild and Atripla. And when we compare Stribild with boosted Atazanavir, we have also similar efficacy, although after 1 year there was very high rate of success, 90% with Stribild, which was, I think, the highest rate we have ever seen in a phase 3 study, but the rate was also very high with boosted Atazanavir. But the difference shows only non-inferiority. When we look at resistance and when we compare Stribild to Atripla and to Atazanavir, which is not on the slide, you see that the incidence of resistance emergence is the same between Stribild and Atripla. So already with Raltegravir, we had this small issue of possibility of emergence of resistance in some cases of failure. Now we see the same with Stribild, that is, in a few patients who have failure, we see emergence of resistance. This is only 3% of the patients overall, but this is the same incidence as for Atripla. And which is also to be noted is that although we have in all cases of resistance with Stribild resistance to integrase, you have also in all cases resistance to NNRTI, which is not the case with the Efavirenz Truvada arm with the Atripla. So you have no protection for the resistance to NNRTI. So this is something probably to consider. Probably also to consider the fact that when you look at the specific mutations, but this is only from one set of population, probably this is cannot be generalized, but most of this profile of mutations can be salvaged effectively by Dolutegravir as a second integrase inhibitors. And I didn't represent Atazanavir on this because there is no mutations whatsoever at virologic failure, nor on the PI, on the protease, nor for NNRTI on the Atazanavir boosted arm. With regards to adverse events, it could be that Stribild is associated with less diarrhea than boosted Atazanavir, so it could be a small advantage. However, the nausea incidence remains the same. And for compared to Atripla in blue, of course, we have less fatigue, less depression, less insomnia, less rash, and less dizziness. So this is what is expected when you compare anything to Atripla. You always win on the CNS aspects or psychiatric aspects. And in total, when you look at the impact of these adverse events on the patient. Less patients discontinued because of adverse events with LV-COVID than with Efavirenz or atazanavir, which reflect probably the better tolerability of the integrase compared to the NNRTI or the boosted PI. And just to note that the concern we might have had at a point with regards to renal tox has not been confirmed with the long-term 2 weeks and 3 weeks data. We have no more incidents of tubulopathy. There are still a small risk, but it is a very limited risk. We need to take it into account by a survey of the creatine function, but I mean, this is not clearly a major issue. With regards to diarrhea, it's a little less than with atazanavir, but still patients can still complain of diarrhea with Stribild. And with regards to nausea, this is an early phenomenon that patients after a few weeks don't mention anymore, and probably this is the induction period of the drug, and probably if they take it strictly with food, it will decrease the nausea at the beginning. So maybe it's a message we can convey to the patient, even if it does not solve always the problem. So now let's turn to TVK, Dolutegravir, for which I'm not going to present all the studies in details. I just want to summarize the very nice data we have in the phase 3 program, phase 2, phase 3 program for the naive population. The first was a phase 2 in 200 patients looking at different doses of Dolutegravir versus Efavirenz plus 2 NRTIs. The second one was a large phase 3 double-blind study in 822 patients comparing Dolutegravir and Raltegravir. And the third one was a double-blind study, single, 833 patients comparing Dolutegravir plus Kayvexa to Atripla in the double-blind design. And the fourth one was Flamingo, was less patients, 484 patients. This was open label to compare Dolutegravir and darunavir. So we have a global picture with TVK, which is a comparison to the 3 major competitors of the different families. So for Spring 1, the dose of 50 milligram was demonstrated as the best, and this was over 2 years with 2 NRTIs superior to Efavirenz, with, as expected, a better tolerability than Efavirenz-based regimen and less discontinuation because of that. And what we saw in this study is that at failure in the integrase groups, there were no single case of emergence of integrase mutations over 2 years of follow-up, which was a new phenomenon within this integrase class, although the number of patients were relatively small, 200, and the number of failures were very low in this phase 2 study. So in the Spring 2 study, which was a double-blind comparison of Dolutegravir 50 mg QD and Raltegravir 400 mg BID, plus either Truvada 60% or Kayvexa 40% selected by the investigator. The endpoint showed at week 48 and week 96, based on viral load below 50 copies, non-inferiority of Dolutegravir versus Raltegravir, and the safety and tolerability was exactly the same between Dolutegravir and Raltegravir, whatever parameter you look at, clinical, GI, CNS, general, respiratory, any symptoms, CK, lipids. It was very similar between Raltegravir and Dolutegravir. We know Raltegravir has a very safe profile, and we found the same safe profile with Dolutegravir when strictly comparing in a double-blind design. The only difference, as you know, was the small elevation of creatinine that we see, like with cobicistat, which is related to the blockage of a transporter in the renal cell, transporter of the creatinine, which blocks the secretion of creatinine and increase by 10-12% the creatinine in the plasma, and this is immediate phenomenon, and this is stable over 2 years and over the time. And so this was the good news, was the safety profile, which was very similar to Dolutegravir. The second good news was confirmation of the Spring 1 study, which is no integrase mutations over 2 years of follow-up in the Dolutegravir group, although we found mutation at failure in the Raltegravir group. So this was confirmation of the phase 2 study. And in single study, we also had very interesting results showing that Dolutegravir Cavexa was superior to Atripla at week 48, and that it was much better tolerated with less CNS events, but also less rash, less discontinuation due to adverse events, and less grade 3 and 4 liver toxicity. So again, a very safe profile compared to Efavirenz. It's not difficult, you would say, but I mean, still, we confirmed a profile which was very similar to the one in Spring 2. And again, no integrase mutations detected through 96 weeks of follow-up for patients failing Dolutegravir. In Flamingo, which was an open-label design, Dolutegravir plus 2 NNRTI selected by the investigator to compared to Darunavir plus NNRTI. Also, we showed superiority at week 48, which was probably based on the rapidity of action of the integrase compared to the more slower action of the protease. And this was, the difference was by 7% of success rate difference at week 48. And tolerability, clinical tolerability was comparable between the two regimens, although there was less discontinuation with Dolutegravir than with Darunavir, and also it was significantly better for the lipid profile with Dolutegravir than with Darunavir. And again, no integrase mutations detected through 48 weeks on Dolutegravir, no emergence of resistance mutations. Single results have been now extended to week 96, presented 2 weeks ago at CROI, and where we have confirmed the confirmation of the superiority by 8% difference, which is a large difference over 2 years with a very high confidence interval for superiority. And let me come back to the point of resistance issue with regards to Dolutegravir, because some people challenge this and say, well, why don't you see resistance with Dolutegravir where you see resistance with the other integrase? Well, this is what we see. So I cannot tell you different things that what we have seen in 800 patients on Dolutegravir over 2 years with around 47 failures, and patients were genotyped as soon as there were above 50 copies. And despite this, we could not find any integrase resistant mutations, and we could not find either NNRTI resistance mutations. And this is probably related to the structure of Dolutegravir, which is different from the other integrase, and which has a more longer time of association with the integrase enzyme and the longer time of dissociation, which explain why it is so potent, and also its flexibility allows for less risk of resistance emergence because it can adapt to the flexibility of the enzyme, and even if there is minor mutations, it is still active. And you know that Dolutegravir retains activity when there are mutations to other integrase inhibitors, which is not the case. The reverse is not true. The second point I wanted to emphasize is very good tolerability. As I said, when we compared in Spring 2 Dolutegravir and Raltegravir, the rate of discontinuation for adverse events was very low, and this was confirmed in single. Of course, with Efavirenz we had 10%, and this was again confirmed in a real-life situation. When you are in an open-label situation, you have only 1 7% of patients discontinued Dolutegravir over 1 year compared to 4% with darunavir. Look, you have 4-5% with PI, you have 6 to 10% with Efavirenz, and with the integrase, it's 3.5% with Raltegravir, and between 1 and 2% with Raltegravir, Dolutegravir. So we are improving the way patients accept and tolerate therapy, and I think this is a big move besides simplicity, activity, and protection to resistance. Let me now, in a few minutes to finish, discuss on some recent data, not so recent, but this is recent, and one more not so recent. This is from the CROI. This is a switch from PI to Stribild, where you have patients doing very well on PI with no side effects, well suppressed for many months, and they are randomized either to continue the PI or switch to STR, to simplify to a single tablet regimen, and we look whether they are maintained their virologic success, and after 48 weeks, 94% of patients simplified succeed to suppress, and it's only 87% with the PI, and this reflects in superiority of Stribild, and this is probably because not only the patients have less GI symptoms with Stribild compared to the PI they were on, but it also because of higher treatment satisfaction because of the simplified regimen. So if we do the same with other integrase, probably we will achieve the same success. So, and indeed, when you do the same with Raltegravir, switching from PI to Raltegravir, you have also, but this is not the switch Merck study, which was a catastrophe because it was done in the US, where they don't look at historical data. And so this is a study done in Spain, where they switch only patients suppressed 6 years on PI. And when they did so, they achieved a similar success rate when switching to Raltegravir, plus a backbone of 2 NNRTI. And they could demonstrate also some additional benefits in these patients with regards to general symptoms, but also with regards to lipids. Lipids normalized, and even more when they looked at the different LDL particles, the large non-atherogenic in yellow and the small atherogenic in green. You see that in the on the left, on the PI group, you have a majority of green atherogenic lipids, while in the Raltegravir group, when you switch, you increase the non-atherogenic and you decrease the atherogenic. So you not only normalize the lipid level, but you qualitatively improve the atherogenic, non-atherogenic profile of the lipid in the plasma. And another important aspect, I think, is that despite the patients were suppressed for an average of 6 years on PI and well suppressed with no blips, when they switched to Raltegravir, they improved their markers of inflammation very significantly. They didn't modify the endothelial markers or coagulability markers, but all the markers of inflammation except IL-10, but IL-6 and CRP especially improved, and we have reproduced that in another study switching from Infectious to Raltegravir. So maybe there is something special in this unboosted integrase in Raltegravir, and we have to learn maybe in the future with TVK whether this integrase with high potency and large diffusion can have further benefit than just the virologic and immunologic classical one. Just to finish, I want to tell you that because of all the excitement with this new class of integrase, we are thinking of alternative strategies when we switch patients. Usually when we have a patient started on a classical regimen, 2 NNRTI plus a third agent for many months, well suppressed, you discuss with him or he asking, can I switch? Should I switch to, wait, okay, but what do you switch to? You switch to 2 NNRTI plus Xprim, usually. We stay very dogmatic. So what could we do today? Probably all of this needs to be evaluated, and probably having a boosted PI is not the most sexy thing to do when switching a patient to for a simplification or for a switch strategy. Raltegravir Maraviroc has failed. We have shown that, and it's too risky with the tropism assay to use this Maraviroc as a dual combo with integrase inhibitor, solid 2 drugs. So one avenue could be a very potent integrase and NNRTI. And you have probably heard at CROI the phase 2b study from Latte, which is a maintenance with 744, which is a baby Dolutegravir plus rilpivirine. And this has proven more efficacious than maintenance with Efavirenz. So now they are moving with 744 in a nano formulation to be for an injectable drug to be given every month probably, with both rilpivirine and 744 as a dual injectable combination for maintenance therapy. So a new study is going to start. So maybe in a few years this will be a possibility for some patients who don't want to take pills forever to switch to maintenance IM therapy. We'll see. But another avenue could be to have a dual combination of integrase and NNRTI orally, and we are going to start in our site and in other in 20 sites in France a study next month. First patient will be enrolled next month, where patients well suppressed on any regimen with no history of NNRTI resistance or NNRTI failure will be either continued or switched to the dual combination of Dolutegravir plus rilpivirine for maintenance. So this will be probably tell us a lot of the possibility to have a regimen which combine 2 very safe drugs and whether it is sustainable for the long-term maintenance.